Thank you so much for the introduction, and thank you for inviting me to speak. I'm really excited to talk about some liver lesions with everyone, and I'm really happy to be here. I'm going to share my screen so I can share my lecture. So let's get this open, and then we'll start. Okay, great. So this is one of my first lectures I'm giving, Imaging Approach to Liver Lesions, and specifically in non-cirrhotic livers. And I have my email address on here, so you feel free to email me if anything was unclear. Okay, great. So let's talk about the objectives of this lecture. So when I was in fellowship, I would ask my fellowship director, I would tell him, you know, Dr. Frank Miller, I want to know the imaging characteristics on MR on how to distinguish benign lesions. Like when I open up a study, how do I know that it's an adenoma versus an FNH or focal nodular hyperplasia, FNH, or a hemangioma or an abscess? And because abscesses can sometimes mimic cancer, or a ciliated hepatic foregut cyst. So these are all benign lesions in the liver. And I said, what MR sequences am I going to use to tell the difference between these different benign lesions? And so we'll go over that. And then know the MR characteristics to distinguish a hemangioma from metastasis, because sometimes it's not as straightforward. You would think like, okay, it's a hemangioma, it's benign, but sometimes a metastasis can kind of throw you off and you might think it's a hemangioma, but there are certain features of it that tell you that it's not. And then also to distinguish hemangioma for something that's not common, I've only seen a couple of cases of it, but angiosarcoma, because that can look like a hemangioma. And then to know the MR imaging features of cholangiocarcinoma, because this we actually do see more often. And we'll discuss hepatocellular carcinoma, so HCC, in a different session. And then know the MR imaging features of the following uncommon malignant lesions. And this one's a mouthful: malignant epithelioid hemangioendothelioma, and fibrolamellar HCC, fibrolamellar hepatocellular carcinoma. So these two malignant lesions, I've only seen twice in, I've seen one case of each in fellowship. So let's start with case one. So this is a 23-year-old female, history of vague abdominal pain, and she had indeterminate liver lesions found on MR. And I'm showing you the arterial phase on both of them, just at different slices. We have one liver lesion here in hepatic segment 2, another arterially enhancing liver lesion here that looks probably hepatic segment 4. So 2 liver lesions. So what are our findings? So we have 2 arterially enhancing liver lesions. And what is the differential diagnosis for that? So one, in a non-cirrhotic liver, we're going to be thinking about an adenoma, right? Adenomas aren't malignant, though one certain subtype can have malignant potential. And then we want to be able to tell the difference between an adenoma and focal nodular hyperplasia. So both of those are in the differential for arterially enhancing liver lesions. And then, of course, if we did have the history that this patient had a chronic hepatitis B infection or cirrhosis, then we would be thinking of hepatocellular carcinoma, which would be covered in a different lecture. And also metastasis, right? You can throw metastasis in the differential for, you know, any liver lesions that are enhancing in the liver. And it's also good to think, could this be metastasis, especially if the patient has a history of some sort of malignancy. So we have a T2 haste, and we know it's T2 because our fluid is bright. And so this is a finding because we don't see anything there where we actually saw that arterially enhancing liver lesion on our arterial phase. We don't see anything there. And also the other thing I wanted to just point out is that you'll see numbers at the bottom sometimes here, and that's just my references. So if you wanted to read more about this finding, number 13 in my reference page, that would be my 13th reference. So just to let you guys know. So this is what's called a stealth lesion. This T2 haste sequence demonstrates that these lesions are stealth, meaning you don't see them. So you could actually miss these lesions if you didn't have a contrast, right? If we just did an MRI without contrast, we would probably miss these lesions. We don't see them on the T2 haze, but we see them on the arterial phase. So there's no corresponding signal identified on our T2 imaging to correspond to that spot where we saw the arterial enhancement. So this sequence, these two sequences here is our opposed phase. This has what is called India ink artifact. It looks like a black outline out of like just outlining all our organs. And then this is our in phase. So they're both at T1 weighted phases. This is what my fellowship director, easy for me to remember, because my fellowship director, Dr. Frank Miller, used to say, this is your pathology phase, because this is when you can look for microscopic or intracellular fat or iron. So what he says, it's like, this is when you can be the pathologist. So when you look here, where we know that we have that liver lesion, you put ROIs on it. I got an ROI of 291 on my opposed phase, and I got an ROI of 327 on my in phase. You want to see if it drops signal on your opposed phase, and you want to see if that drops by 15%. If it drops more than 15%, you know that you have intracellular or microscopic fat in this liver lesion. Here, we don't. 327, 291, we don't have dropout in this liver lesion. So there's no signal dropout on our opposed phase compared to our in phase. And signal dropout would be characterized by 15% of drop of signal on the opposed phase compared to that in phase when you're comparing those ROIs. So we know there's no intracellular, we know there's no microscopic fat in this lesion. Oh, sorry. And we do know that some hepatic adenomas, particularly the HNF1 alpha subtype, those subtypes can have intracellular microscopic fat. We know that this lesion doesn't have that. So this study was actually performed with hepatobiliary specific contrast. So this is a contrast agent. We wait 20 minutes. It's a 20-minute hepatobiliary phase. And lesions that are basically functioning hepatocytes, right? So our liver is going to pick up that contrast, and any lesions that have functioning hepatocytes are gonna retain that contrast. And where we saw that liver lesion in hepatic segment 4 and that liver lesion in hepatic segment 2, we do see that, hey, they're bright here. They did take up that contrast. They retained it on the 20-minute hepatobiliary phase. So for the hepatobiliary specific agents, lesions without hepatobiliary function will not retain or accumulate that contrast, right? Even benign lesions, cysts, hemangiomas, adenomas, or even other processes such as metastases, those don't have hepatobiliary function, so they're going to be dark holes on there. And why is this sequence helpful in this case? Because these lesions did retain them, right? They were bright on that 20-minute hepatobiliary phase. They're not dark, they weren't hypo-intense. So they do have functioning hepatocytes. And then here I have a video just scrolling through these lesions. So we know that they retain that contrast in the 20-minute hepatobiliary phase. And also, it's kind of just with this specific sequence, we do see excretion of that contrast into our common bile duct, our gallbladder, which also can make this sequence helpful, like if you wanted to evaluate for biliary leaks. So this is all being excreted in that gallbladder and common bile duct on this video. And the liver is bright because it's taking or retaining that contrast. So this is focal nodular hyperplasia. So let's just put all these findings together. We had 2 arterially enhancing liver lesions. And in a non-cirrhotic patient or in a patient without chronic hepatitis B, for an arterially enhancing liver lesion, we're thinking FNH versus adenoma with no history of malignancy. Then we went to our opposed phase and in phase to see if there was intracellular fat or microscopic fat. And if there was, that would push us to an adenoma, and there wasn't. And then we looked at a 20-minute hepatobiliary specific contrast phase. And we saw that it retained that contrast. That lesion retained that contrast. So it had functioning hepatocytes, so it's compatible with an FNH. So for focal nodular hyperplasia, or FNH, this is just abnormal arrangement of a normal hepatocytes with some dense fibrous tissue, malformed biliary drainage. That's why it retains that contrast. It retains our hepatobiliary specific agent contrast, because they are essentially hepatocytes. And they can have a central scar. So the central scar is T2 hyperintense, and it enhances on post-contrast sequences. And this is important to distinguish that from another entity that we'll talk about as fibrolamellar HCC. And it's the second most common benign liver lesion encountered. So we actually do see these a lot. And it can be helpful to kind of know that, hey, let me look at the opposed phase and in phase to see if it has fat to push me towards an adenoma. Or can I use a hepatobiliary specific agent to see that it retains it on the 20-minute hepatobiliary phase to say that, yes, this is an FNH. Hemangioma is actually the most common benign liver lesion encountered. Females get this more than males. About 10 to 20% occur in males. And this can actually occur after chemotherapy, such as oxaliplatin. So for example, we had a case when I was a fellow at Northwestern, where we had a patient who had MRIs every few months. We were following some lesions, and a new lesion popped up. And we did it with a hepatobiliary specific agent, and it retained that contrast on the 20-minute hepatobiliary phase. And we were thinking to ourselves, wow, this is a new FNH in this patient. And we found out that they were on this chemotherapy. And approximately 80% of FNHs, so by far most of the FNHs you're going to encounter are going to retain that hepatobiliary specific contrast. But just like medicine in general, right, not all of these lesions are going to follow this finding. So you can have atypical FNHs that can have intralesional microscopic fat. So then you might be thinking like, wow, is this an adenoma? But then it does retain contrast on our 20-minute hepatobiliary phase. They can have pseudocapsules. They can have non-enhancement of the central scar, right? For central scar in an FNH, we expect to have enhancement on post-contrast images. So your atypical FNHs are going to be more of a diagnostic dilemma, where you kind of, sometimes you're really not going to know until what's going on. Maybe we follow it, maybe we get a biopsy. Okay, so let's move on to case 2. So we have T1 fat sat arterial phase, and we have an arterially enhancing liver lesion. So arterially enhancing liver lesion, we got to be thinking of our differential now, right? So now we know FNH is going to retain that hepatobiliary specific contrast if we had that phase. An adenoma is in our differential for an arterially enhancing liver lesion in a non-cirrhotic patient. And so you're going to want to look, right, for intracellular fat, as we talked about on our post phase and in phase, or you're going to want to look at your T1 sequence, because the other things that we know about adenoma is they can have intracellular fat, or they can be T1 fat sat hyperintense, meaning they bleed. And of course, metastases, just like in our last case. We can always throw in metastases for this. We want it in the back of our minds. We want to be thinking like, could this be metastases? Of course. And HCC in a cirrhotic patient or chronic hepatitis B. Okay, so here's our opposed phase and our in phase. So on our opposed phase, 197 was our ROI, and on our in phase, 308. So it did drop out. Signal dropped out from our in phase compared to our opposed phase, more than 15%. And visually, you can see that. You can see that, okay, here's a lesion there. We know that that was where the arterially enhancing liver lesion was. And then you look on our opposed phase and it's darker. It dropped out signal. So we do have focal dropout signal on our opposed phase compared to our in phase. And that's more than 15% signal, just objectively and subjectively, right? Objectively, we can actually measure the ROIs and see if it dropped out more than 15%, which it does. And then subjectively, it looks like it's dropping out. And so if we know that this is our pathology sequence, we know that there's intracellular or microscopic fat in this lesion. So this has to be an adenoma, right? So putting this case together, arterially enhancing liver lesion and our opposed phase and out phase show us that there is intracellular or microscopic fat, showing us that this is an adenoma, specifically HNF1 alpha subtype. So there are 3 different subtypes of adenomas. The most common are the inflammatory subtypes. These are the ones that have the highest bleed rate. So you think to yourself, well, what is a bleeding liver lesion gonna look like on MRI? So on MRI, they're gonna be T1 hyperintense on pre-contrast imaging. And they can also sort of be T2 hyperintense, but really that T1 weighted sequence, if it's bright on your T1 weighted sequence, you're thinking this, you know that this thing is bleeding, and you're thinking adenoma, and specifically inflammatory subtype. Now, the inflammatory subtypes are the most common, and this subtype can retain hepatobiliary specific contrast on the 20-minute hepatobiliary phase. And this one can also be confused with FNH. So again, this would be the one lesion that would sort of give you that diagnostic dilemma where you're thinking to yourself, I have a bleeding liver lesion, but it retains contrast on our 20-minute hepatobiliary phase. But your FNHs, your focal nodular hyperplasias, should not bleed. And then this case that we had here are HNF1 alpha subtype, these mutated subtypes. These are the second most common. We also often see them multiple. They don't really bleed, but you see intracellular microscopic fat, as in the case that we had. And really, you see them in females that are on birth control pills. And then the least common is the beta-catenin mutated type. And these are men that are on anabolic steroids, patient with glycogen storage disease, and these are the ones that have the highest rate of malignant transformation to HCC. Okay, let's move to case 3. This is a 32-year-old female, history of thyroid cancer. Young female, but we do have the history of thyroid cancer, and she came into the ER, and I'll show the video. Came into the ER with abdominal pain, has a history of thyroid cancer. So we see all this hyperdense ascites around the liver. So we're thinking she's bleeding. She has hemorrhagic ascites, a lot of it. And we see a liver lesion in the inferior right hepatic lobe, and there are these small foci of, active bleeding in this lesion. So what are our findings? Bleeding liver lesion in a young patient. So anytime you see a young patient without cirrhosis, without chronic hepatitis B, you can think to yourself, can this be an adenoma? The problem here was she did have a history of thyroid cancer. So we wanted to proceed with caution here. So we recommended an MRI. So on the MRI, we have our T1 pre, and then we have arterial, and then we have our post-phase and out-of-phase. So it is very bright on our T1, which is expected because we knew that it was bleeding. And then if you just visually look at the arterial compared to the pre, it doesn't really look like there's enhancement there. It's bright on our arterial phase because it's just intrinsically bright on our T1 pre. And then you look at your post phase and in phase, there's no dropout of signal to suggest there's microscopic or intracellular fat. And then we got the subtraction images of arterial phase just to prove to ourselves that, yeah, there was no enhancement in this lesion, no enhancement. So this lesion is T1 hyperintense. We know that it was bleeding that we saw on CT. We didn't really see arterial enhancement, right? That was confirmed with their subtraction images, and there was no intracellular or microscopic fat, but we still were leaning that this was probably an adenoma because she did not have history of cirrhosis, no chronic hepatitis B, bleeding liver lesion. We were thinking adenoma, but we were still concerned because of that history of thyroid cancer, so we got a PET CT. The PET CT showed that it was not avid. It did not it did not have FDG activity. And then we did a biopsy because the clinical team was a little bit concerned because she did have that history of thyroid cancer. So pathology results. So it was an adenoma. So it made everybody feel better that, we weren't missing a metastasis. And given that it was bleeding, I had my fingers crossed. I was like, this is going to be an inflammatory subtype adenoma because it's bleeding. But it came back as not otherwise specified. But yes, it was an adenoma. It was a bleeding liver lesion in a young patient without cirrhosis or chronic hepatitis B. Okay, case 4. 46-year-old female, and she had an MRI for a liver lesion that was identified on ultrasound. She got the ultrasound for abdominal pain, saw a liver lesion, didn't know what it was. They got an MRI. So This is she had an MRI 4 years ago. And on this T2 haze, we sort of saw this small little area of T2 hyperintensity. I don't even know what we said about it at that time. Like maybe it was a small cyst, wasn't really concerning. So 4 years later, this is our T2 fat sat. So now this area, we have central, really strongly T2 hyperintense. It's bigger, and all this stuff surrounding it is sort of heterogeneously T2 hyperintense. But it is not, the sort of central portion is really, really, really bright, really, really T2 hyperintense, and the other stuff around it's heterogeneous. And then we have our DWI, right? Our high B weighted value imaging, our B800, and our ADC map. Now this is helpful because it can tell us if something is solid, so is it hypervascular? It doesn't necessarily tell us if something's malignant. It just tells us it's solid. There's maybe there is truly a mass lesion in here, whether it's benign or not. And also it can tell us if something, right, infection can be really cellular. So here, that central portion on our DWI and our ADC map, it's bright, so there's no restricted diffusion in that. If it's dark on our ADC map, bright on our DWI, you're thinking it has some restricted diffusion in it, meaning it's cellular. There's probably some soft tissue there. And you can see that the stuff surrounding it, some of the stuff is bright with corresponding dark signal on our ADC map. So then we have our pre and our post contrast arterial, portovenous, equilibrium, and delayed phase images. So here, it is a little bright on our T1, very arterially enhancing. We have that central portion that's not enhancing. That central portion is really not enhancing on any of our on our sequences, and it does have persistent delayed phase imaging. On this patient, we just so happened to get the 20-minute hepatobiliary specific contrast on board, and it's dark on there. And I mean, it's not an FNH, right? Probably not an FNH. So findings: heterogeneously T2 hyperintense, increased in size from 4 years ago. It's a little heterogeneous on T1, a little bright on T1. And we have the arterial enhancement, persistent delayed phase enhancement, and no retention of contrast on our 20-minute hepatobiliary phase. So the differential diagnosis, I remember all my attendings sitting around and saying, I don't know what this is. So they said, it's not retaining the contrast on the 20-minute hepatobiliary phase, but are we dealing with an atypical FNH? Are we dealing with an adenoma? Because we did sort of have some mild T1 hyperintensity, and specifically the inflammatory subtype. And then could we be dealing with a fibrolamellar HCC? Because we did have that central non-enhancing area, that very bright T2 hyperintense non-enhancing area. Could this be a non-enhancing scar? So that was in the back of our minds. So they biopsied it because, I mean, we didn't know what it was. And they actually did a partial right hepatectomy, and it came back as a hepatic adenoma, telangiectatic, I have trouble saying that one, type. And I had never heard of this. I'd never heard of this. So basically the telangiectatic subtype adenoma, this was previously called telangiectatic focal nodular hyperplasia. Apparently for years it was called this, and the classification changed it to an adenoma, a subtype of adenoma, just based on molecular and genetic evidence that had been gathered. Females get it more than males, and they do have a potential for malignancy. They are behaving more neoplastic rather than regenerative. And the treatment is surgery. This patient had got a partial right hepatectomy. So MRI findings, as if you would read in the reference, just strongly follows our case. Strongly T2 hyperintense, which we had here. And it was, some T1 hyperintensity. It wasn't dark on T1, right? Especially if you have, some liver lesions, they'll be dark on your T1 amongst your bright, just liver, intrinsic bright liver on here. And so this was a little T1 hyperintense, and we did have that persistent delayed enhancement. And in the literature it says like maybe that persistent delayed enhancements from sinusoidal dilation from this lesion. So when we're talking about arterially enhancing liver lesions, we do have to be careful, because we want to make sure, if we have an arterially enhancing lesion, we want to make sure this patient does not have cirrhosis. They do not have chronic hepatitis B infection, right? Because once you have cirrhosis or chronic hepatitis B infection, then you have to start thinking of HCC, and we'll cover that in a separate lecture. Because HCCs can have intracellular fat and they can bleed like adenomas. And while differentiated HCCs can retain the contrast on that 20-minute hepatobiliary phase. So it's very important that we know that this patient does not have cirrhosis or chronic hepatitis B. And that will be covered in a separate lecture. Okay, great. So let's move on to case 5. I have a T2 haste, arterial, post-contrast, and delayed. I'm sorry. So on our T2 haste, I like this because it's very bright, right? Like you kind of look at your gallbladder, like this lesion is very bright, just kind of like your gallbladder is. I like this lesion because it's a type of lesion I'll look at and say, oh, it's a cyst. And then you go to your post-contrast images and you're like, oh, it's not a cyst, it's enhancing. It's peripheral nodular discontinuous enhancement that fills in on delayed phase imaging. And you're like, oh, it's a hemangioma, right? So T2 hyperintense, that is a very, very important feature of a hemangioma. And I bring this up because there are times where there were pitfalls where people calling hemangiomas when they weren't T2 hyperintense. And that's what my fellowship director would always tell me. Is this lesion T2 hyperintense when he would see that enhancement pattern? Yes. Okay. I feel good it's a hemangioma. Peripheral nodular discontinuous enhancement. And enhancement increases with delayed phase imaging. But if you have peripheral nodular discontinuous enhancement and enhancement increases on delayed phase imaging, but it's not T2 hyperintense, you do not call it a hemangioma. Could it be an atypical sclerosing hemangioma? Absolutely. But those are one of those lesions that are diagnosis of exclusion. Either we get a PET CT to prove that it's not avid, or they biopsy it, or we just follow it for a long time. So putting this case together, the most important feature of a hemangioma is T2 hyperintensity. That's what Dr. Frank Miller used to hammer, 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 hammer. Very important feature of a hemangioma is T2 hyperintensity, or you cannot reliably call it a hemangioma. And they will not retain contrast on the 20-minute hepatobiliary phase, right? Because they don't have hepatocytes like an FNH. And they will not spontaneously bleed like an adenoma. So if you have a patient that doesn't have cirrhosis or chronic hepatitis B, and you have a bleeding liver lesion, you think adenoma. If you have a patient with cirrhosis or chronic hepatitis B and they have a bleeding liver lesion, you have to exclude HCC. So let's go to case 6. We have a 50-year-old female. Now we do have a history here of cirrhosis. So I am showing you our T1 fat saturation pre-contrast and our post-contrast phase, arterial, portovenous, equilibrium, and delayed phase. So on our T1 pre, it's a dark lesion here. It's a T1 dark lesion. And then we look at this and we're like, oh, here we have some nodular peripheral enhancement, discontinuous, right? It fills in on delayed phase imaging. Okay, hemangioma, are we done? No, right? We got to look at that T2. We either need a T2 haste or we need a T2 fat sat, and it needs to be bright. So here's our T2 fat sat. I mean, it is a little bit T2 hyperintense, but not like we want our hemangiomas. We want those T2 bright. Like I want it to look like a cyst on my T2s. And, you know, it's not very T2 bright. It's sort of heterogeneous. We come over here on our diffusion weighted imaging. It's, you know, a little bright on our DWI, but it's not dark on our ADC map. So we're not really, doesn't really look like it's very cellular, but shouldn't sway us. We know that there is a lesion, a solid enhancing liver lesion here. And then we have our in phase and our opposed phase, and there's just no drop on our opposed phase. There's no microscopic fat or intracellular fat to make us think like this could be an adenoma, a weird atypical adenoma. So findings: peripheral nodular enhancement, progressive filling onto late phase imaging. That's what a hemangioma does, right? But heterogeneous T1 and T2 signal. It's not T2 hyperintense that we want our hemangiomas. So now we have to expand our differential. So we included atypical HCC in this differential because it was in a cirrhotic patient. we included cholangiocarcinoma because we had a cirrhotic patient, and cholangiocarcinomas can kind of have some various imaging features, so we included that. We included angiosarcoma and atypical hemangioma, which would be the diagnosis of exclusion. So they biopsied this, and this turned out to be a low-grade angiosarcoma. These are very rare lesions, 1% of all liver tumors. Like I've said, this is probably the only case that I've actually seen at the reading station and not in one of the references. And by the time you see these patients, metastases are common. You're going to see metastases on in the lungs and the spleen, and they have a poor prognosis, unfortunately. Imaging characteristics, exactly what we saw in this case, T2 and T1 heterogeneous, and this is just due to solid tumor and also hemorrhagic components. And post-contrast, peripheral nodular enhancement with progressive filling. This is what can get us where we are thinking it's something benign when it's not. Okay, let's go to case 7. We have our T1 FATSAT pre and a T2 FATSAT, and then we have a T2 HASTE and then T2 HASTE coronal. So we have this infiltrative mass in the left hepatic lobe, this sort of gray infiltrative mass that's replacing that left hepatic lobe. And also, if you look on the T2 FATSAT, you do see that there is associated intrahepatic biliary dilation. You see all these dilated bile ducts, they're bright. And it's really brought out on this T2 FATSAT. I mean, you can't see it on the T2 HASTE, but you really see it on this T2 FATSAT. You look at the liver contour, and there is some capsular retraction right here. You do see it looks like the capsule's being pulled back. And then here is our ADC map and our high B-weighted value imaging, or DWI. And we see that this is dark on our ADC map, bright on our DWI. So it has marked restricted diffusion. It's just telling us there's something really hypercellular here, really cellular process going on here. So again, here's our T1 pre, and then our T1 FATSAT arterial, portovenous, and delayed phase. So this infiltrative mass in the left hepatic lobe, sort of heterogeneously arterially enhancing, and then it has increased enhancement on delayed phase imaging. We started to see more enhancement centrally within this lesion than we did on the arterial phase. So this is cholangiocarcinoma. So cholangiocarcinoma, overlying hepatic retraction, which we had here, may have intrahepatic biliary dilation, which we had, and increased enhancement on delayed phase imaging. I mean, that's what cholangios do. Sometimes they may even be dark on our arterial phase, and it doesn't really look like there's a lot of enhancement, and then you go to a more delayed phase and you're like, wow, this thing is progressively enhancing. And we can see the cholangiocarcinoma in the setting of cirrhosis, and specifically we can have mixed HCC cholangio lesions, and these are what we call the LIRADS M lesions in cirrhotic patients, and these usually need a biopsy, and we'll discuss this at our other lecture. Okay, great. Case 8. So 23-year-old male, he's young, 1 month jaundice and epigastric pain, 15-pound weight loss. So that's concerning history. No history of cirrhosis or chronic hepatitis B. And I'm giving you our T2 FATSAT axial, T2 FATSAT coronal, and our diffusion weighted imaging, high B weighted value, DWI, and our ADC. So on our T2s, we see that there's this lesion here in the left hepatic lobe that is sort of heterogeneously gray. We do see that it is causing biliary dilation here, this mass, where I put all my arrows. And on our diffusion weighted imaging, it's bright on our high B weighted value imaging, and it's dark on our ADC map. So yeah, it's hypercellular. So then we got our T1 FATSAT pre, and then we have arterial, portovenous, equilibrium, and delayed. So it's dark on our T1 pre, heterogeneously arterially enhancing on our arterial phase, and then it it has persistent delayed enhancement, sort of becoming more iso enhancing on delayed phase imaging. We kind of look centrally and we're like, hey, is there a central scar here? Central scar, that's not enhancing. So what do we have here? We have heterogeneously enhancing arterial lesion, delayed iso enhancement, and is there a non-enhancing central scar? Was one of the imaging features my attending had noted. So the differential diagnosis, well, we'd be thinking young patient, a mass that maybe has a non-enhancing central scar. Could this be a fibrolamellar HCC? Of course, we thought of metastases. And then we threw in some, could this be something benign like an atypical large hemangioma, FNH, or adenoma? Again, that would be diagnosis of exclusion. We were leaning more with fibrolamellar HCC or metastases. So we asked them to get a PET CT. They got a PET CT. This excludes anything benign. I mean, this thing is very FDG avid. So we know that the soft tissue is concerning for malignancy. So fibrolamellar HCC is what the biopsy showed. So these are usually younger patients, 20 to 40 years old, not associated with cirrhosis or chronic hepatitis B infection. These patients don't have cirrhosis or chronic hepatitis B. And the central scar has been reported in the literature anywhere from 20 to 71% of cases. And it can be stellate or sort of amorphous on imaging. They can have significant lymphadenopathies. Usually see more than 50% of the time when you actually see them on CT or MRI. This patient didn't. So for CT, they're gonna have a central scar. The central scar is just this dense fibrotic bands. They can have calcifications on CT, which are harder to see on MRI. And they can have slow, show progressive and persistent enhancement. And on MRI, this is exactly what we had. Heterogeneous arterial enhancement, delayed iso enhancement, can have washout, and the central scar is usually hypointense on all sequences. Okay, let's go to case 9. This is a 71-year-old male, history of liver failure and cirrhosis, so we have cirrhosis, and jaundice and weight loss. So this case was tricky. We have our T1, fat saturation pre, and then our post-contrast arterial, portovenous equilibrium and delayed. So we look here and just look at the liver contour, and this was actually pointed out by my attending when I had read this doesn't look like a cirrhotic liver morphology necessarily. It's really lots of areas of capsular retraction. And then you start to look and you're saying to yourself, hey, is this a lesion right here? Is there another one here, another one here? So what we have is all these lesions in a peripheral or subcapsular distribution with capsular retraction. And then on delayed phase imaging, it's heterogeneous, but you have this increased enhancement. And then we have our T2 haste and our diffusion weighted imaging. So our T2 haste, we do have some artifact on here because he had a lot of ascites, but we look here and we're like, man, this liver is just really heterogeneous. We're suspecting there's these liver lesions. So you just have lots of areas of capsular retraction. Our diffusion weighted imaging showed us like peripherally, there's just this rind of bright DWI signal. So we're thinking, is there just a lot of liver lesions out there in the periphery? So what do we have? Heterogeneous T2 signal, multiple liver lesions in a subcapsular distribution. These liver lesions have peripheral arterial enhancement, and we're seeing restricted diffusion in these lesions. So our differential diagnosis was cholangiocarcinoma because giving overlying capsular retraction, HCC because we do have that history of cirrhosis. And they biopsied it, and it was malignant, epithelioid, hemangio, endothelioma. Mouthful. And these are seen in males more than females, about a 3-to-2 ratio. The age range is usually 30 to 50, and this patient was in his 70s, so he was out of the age range. But on CT, you're the same thing you see on MRI, multiple peripheral masses, subcapsular in location, capsular retraction, right? That's what makes us think like, could this be cholangiocarcinoma? And they can have a hypoenhancement to heterogeneous enhancement. And they have this sort of halo or target pattern of enhancement that we saw in this case. On MRI, on our T2 weighted sequence, we see heterogeneous to hyperintense, And on our post-contrast, which we saw in this case was peripheral enhancement or target-like enhancement. Okay, let's go to case 10. It's T2 haze, T2 fat sat, and T1 fat saturation pre. So we have this large liver lesion in the right hepatic lobe. It's cystic, but it has a lot of nodular septations. Complex T2 hyperintense cystic lesion, multiple septations. We come to our delayed phase sequence, and then we have our DWI. So those septations are enhancing, but there's not an enhancing mass. It's just the septations that we're enhancing. And on our diffusion-weighted imaging, we have marked restricted diffusion along the periphery and within those septations. No enhancing nodular soft tissue. So this was an abscess. This was actually drained. A drain was put in at some point by IR, interventional radiology. This patient had a history of appendicitis and had this lesion, just to show you that even though this has marked restricted diffusion, doesn't necessarily mean that there is a malignant mass in there. We can also see this with infection or abscess, and not always tumor or solid lesion. So this case 11, is a history of breast cancer. T2 fat sat and T2 haze. Now I will tell you this case this patient had 3 MRIs in a year. The past 2 MRIs were read the same and they were read incorrectly. So we have this heterogeneous T2 lesion, right? Maybe it has this small area of T2 hyperintensity, but it's not very T2 bright like the gallbladder, right? This is sort of gray. It looks like soft tissue in there. Heterogeneously T2 hyperintense lesion. So I have a pre and a post, and we have 2 lesions actually. And what does this lesion have? Is this peripheral nodular discontinuous enhancement? No, this is ring enhancement. You have contrast all the way around that peripherally enhancing. This was read over 2 MRIs as hemangioma. Why don't we like that for hemangioma? Well, one, it's not T2 hyperintense. It has that small central T2 hyperintense component, but it's not a diffusely T2 hyperintense lesion, and it's not peripheral nodular discontinuous enhancement. This is rim or ring enhancement. They biopsied. Oh, sorry. And then we have our diffusion-weighted imaging. And the reason why it was read as not metastasis is because it doesn't look like it has restricted diffusion. It's not dark on our ADC map. Yeah, it's bright on our DWI, but they were thinking that was T2 shine through, which you can see with cystic lesions, because you want it to be dark on your ADC map. So they said, oh, there's not restricted diffusion in this, so it's probably not malignant. So these lesions are most consistent with metastasis. Given that history of breast cancer, they're not consistent with hemangioma at all. They do not have any imaging features of hemangioma. They're not T2 hyperintense. They don't have peripheral nodular discontinuous enhancement. They biopsied these lesions, and the past showed metastatic adenocarcinoma consistent with breast primary. So for hepatic metastases, hypervascular metastases can show early continuous ring enhancement, which we saw here. And this is when it can sometimes be confused with the hemangioma. And larger lesions that are, 1.5 centimeters or larger can show rim enhancement and washout. And this is what's going to distinguish it from a liver hemangioma as well. What do we talk about with hepatic hemangioma? We want those very T2 hyperintense, and we want peripheral nodular discontinuous enhancement. And yes, it was, you can see them sometimes be hyperintense hemangiomas on DWI, even on our high B value images or B800s. And this just may be due to blood flow, and they can have mixed intensity on ADC. So sometimes the DWI can lead you astray, like in this case where you're saying, oh, there's not a lot of restricted diffusion, probably not a MET. It's really what does it look like on the enhancement and your T2. So this cystic lesion is, you can make the diagnosis because it's in a very specific location, right? This T2 haze, we have a cystic location. This is a ciliated hepatic foregut cyst. Findings: T2 hyperintense lesion, cystic lesion in a specific location in the liver. Location. My fellowship director and our section head here at the University of New Mexico love to show this. They love to show this to residents, trainees, medical students, because you see it and you say it's a cyst, and it has all the imaging features, right? It's a T2 hyperintense non-enhancing lesion. But this one's a little bit different because it's subcapsular in location, and it's in hepatic segment 4 of the liver. It's solitary, non-enhancing, and these are benign like a cyst, but they get the small malignant potential. But I've asked my fellowship attendings, as well as attendings that I trained with in residency, and nobody recommends follow-up on this. And the literature actually says like the malignant potential is very tiny, that they don't actually recommend follow-up either. So just to recap here before we end. So for arterially enhancing hepatic lesions, right? We want to know, does that patient have cirrhosis or chronic hepatitis B? If they do, if they don't have cirrhosis or chronic hepatitis B, does that arterially enhancing liver lesion have intracellular fat, microscopic fat, or T1 hyperintense to suggest bleeding, like this case that we saw, right? So that would be an adenoma. Do we have a 20-minute hepatobiliary phase? Did it retain contrast like we had in this case? It does. It's an FNH. And then does the patient have cirrhosis or chronic hepatitis B? Does that lesion have intracellular fat, T1 hyperintense bleeding, washout, or capsule? We're dealing with HCC, and we'll talk about that in a separate lecture. So hemangioma, right? We want that to be T2 hyperintense, peripheral nodular discontinuous enhancement, increase on delayed phase imaging. Metastasis or hypervascular ones, right? These are very heterogeneous on T2, and they can have that ring or rim enhancement. And then angiosarcoma, right? These are heterogeneous on T1. They're heterogeneous on, and I should put heterogeneous on T2 as well, just due to hemorrhagic and soft tissue component. And those have peripheral nodular enhancement with progressive filling, but they're not right on T2. Cholangiocarcinoma, we're going to have overlying capsular retraction, intrahepatic biliary dilation, and delayed enhancement. And malignant epithelioid hemangioendothelioma, multiple peripheral lesions, subcapsular in location, and can have a capsular retraction. And they're sort of going to have this target or peripheral enhancement that we had here. Thank you. So these are my references. I mean, I can give this lecture. I don't mind. Anybody can have these cases. And all these cases were from Northwestern Memorial Hospital and the University of New Mexico as my time as a fellow, resident, and attending. Thank you.
Thank you, Jack. It was a very elaborated and wonderful presentations. So I'd like to go on to our Q&A session. So I have a few questions for you. Here's a question like, when you see a probable hemangioma on CT, because that's what we routinely do, the CT, you see a peripheral nodular discontinuous enhancement. When do you suggest an additional MRI? How often should you? Okay.
Yeah, that's a great question. If it's a young, if it's a patient that I know doesn't have any history of, malignancy, or they don't have cirrhosis or chronic hepatitis B, I wouldn't recommend an MRI. If it looks like a hemangioma and there's no reason for me to think like, could this be a MET? So I'm sure that it's peripheral nodular discontinuous enhancement on CT, not ring enhancement, right? If anytime I'm seeing ring enhancement, even on CT, I think, oh, I need to get an MRI. Or if the patient has cirrhosis, I'd either say, this is probably a hemangioma. We can follow it with CT, or we can get an MRI to sort of, look for those imaging characteristics to put it to rest.
Yeah, right. I hope that answers pretty well. Or sometimes maybe we can correlate just with an ultrasound as well.
Exactly, yeah.
Yeah. Well, I have another questions like uh probably we haven't been doing much hepatocyte specific contrast agents. So how different MRI characteristics of focal liver lesions uh, can help without using non-hepatobiliary specific contrast agents?
Yeah, so it's when I was at Northwestern, they did a lot of imaging with the hepatobiliary specific agents. At the University of New Mexico, we started doing it more, but we definitely didn't do it as much as Northwestern. And there are some places here in the US that just do hepatobiliary specific only MRI. And so I feel comfortable, like when I protocol my exams, I don't really use hepatobiliary specific agent unless I know, like maybe they had an MRI and they had an arterially enhancing liver lesion, but there was no T1 hyperintensity to suggest it was an adenoma, or there was no intracellular fat to suggest an adenoma. I would either say, we could follow this on even ultrasound just to make sure it's not getting bigger. But we can repeat with the hepatobiliary specific agent if the diagnosis of FNH would change management of this lesion.
Right. Thank you. And here I have an interesting question from Nguyen. Uh, let's see, we have an angiosarcoma suspected in MRI. So should we biopsy it due to high risk of bleeding, or should we prepare for backup surgery or DSA for embolization? This is interesting for me as well because I am being an interventional radiology.
Yeah, I mean,
You like to deal with it.
yeah, that's a great question. I've actually never I've never really, because I've just seen that one case. If I ever ran across a case where there was multiple peripheral lesions, um, I think that, and that would be in my differential now. But I think I honestly don't know what the clinical team would do. I know that they biopsied those lesions because we didn't really know what it was, and they probably biopsy. Or sorry, this is for angiosarcoma. I'm sorry. You asked about angiosarcoma. I
Right.
was thinking about the other one. So for angiosarcoma too, I still haven't seen that many of them. Again, the differential for that, peripheral nodular discontinuous enhancement. I would throw in that, this looks like an angiosarcoma. But maybe they would probably biopsy it since it's just really not seen.
Hey,
I
personally,
don't know.
yeah, personally, if I would want to answer this question, I would rather not go for biopsy, but do an FNA at least with a very thin needle.
It's a great question.
Okay.
There is a question from the attendee. So in the Q&A box, Dr. Ranabhat, can you present that to Dr. Teresa?
Yeah, I have just received a question. Could you explain to me how to do best MR imaging protocol, like timing for arterial phase, venous phase, equilibrium, and delayed phase?
Yeah. In my next lecture, I can actually put that on there. But with the protocols, I actually really rely on my techs for that because they have the settings on the MRI. So I mean, like in terms of timing, I just tell them I want an arterial or I want port venous. So I will definitely look that up though, and like have a more detail of that on the next lecture, just like a quick, hey, this is just how to optimize protocol, if that's all right.
Yes, it's all right. So I have to interrupt a little bit because there is a question from one of our attendee. When you use gadocytic acid, how often you experience transient tachypnea? during the arterial phase? And do you have any suggestion how to handle it?
Yeah, I've actually never I've never ran into that when we have done that imaging. So I don't know what I would necessarily do. I mean, I think I would go and sort of like examine the patient, but I've never actually ran into that side effect.
Thank you. Thank you. So I have a question. This is really hot topic everywhere, AI. Is there any AI in hepatic imaging? That is really a hot topic at the moment.
So one of the, yes, and I think it's like in terms of just like liver, so for just liver imaging.
Yes.
Yeah, I mean, one of the things that is being talked about more is that overlap between FNHs and adenomas, where you have those atypical FNHs that can have intracellular fat, and then you can have the adenomas that retain that contrast. So there's this overlap and confusion on those. And so I know that there's a lot of you know, we're trying now to like really understand it and to really like try to pinpoint how we can put them into categories to be more confident on whether we're dealing with an FNH or an adenoma in those atypical situations. Or was this specifically for AI?
Yeah, I wonder because it's everywhere. Even in the cardiothoracic, we start using like there are an idea to do AI to detect the cardiac device. Something like that. So I thought, yeah, I do not know anything about
for
it.
AI. Yeah, we don't have I mean, we're not using anything here.
Okay.
The University of New Mexico, and we didn't use anything at Northwestern. The only thing that we did at Northwestern that was sort of AI was with pulmonary nodules.
Okay, all right. Is there any new exciting gadolinium in the liver imaging that helps you a lot in the differentiate diagnosis? Any new things in the about the gadolinium contrast, or it's about the same like 10 years ago?
Yeah, it's about the same just now with our with our hepatobiliary specific agents, but yeah, it's been pretty much about the same that I know.
Thank you, Martha. Thank you. JP, do you have anything to ask?
Yeah, hi there. Hi, Dr. Martha. This is JP. I'm one of Nat's colleague working in Wake Forest. Wonderful lecture. Likewise, greatly explained. Awesome. I also do. I've done my body fellowship, and I also do part of my week. I work in body. One quick question. So they have this new classification of MCN in liver cells, mucinous cystic neoplasms. Is there a best way to differentiate between MCN versus simple cyst of liver? Just because, I mean, MCN was always there. It's been renamed from biliary cystadenomas. So is the management of biliary cystadenoma or MCN would change from simple cysts in liver, right?
Yes.
They wouldn't bother the simple cysts. But is there a imaging characteristics which can differentiate them?
Yeah, that one, those ones are hard. And I actually, I should have included one of those cases here. Was I had was running out of time, but I mean, my understanding from those is sort of the sort of like if they're very large or the multiple septations within these lesions. And sort of the enhancement of the septations where you have to be thinking of, hey, could this be this other lesion? But they are tricky.
Yeah, true. Yeah, thank you so much. One more quick thing. Just your experience on abbreviated MRI. Are you at the University of NM? Are you guys working on any abbreviated MRI for liver lesions? No.
We're not, no. But
Okay.
I mean, yeah, that would actually be a really good something to look at.
That's
Because like
exactly, that's
Northwestern, I'm sorry, go ahead.
So sorry. So that's the buzzword, abbreviated MRI. Everyone wants to do an abbreviated MRI. That's hot topic in RSNA too, actually.
Yeah, it would be something that would be great to do because, like at Northwestern, they had the resources, they had multiple MR machines, and so they could do all these sequences that weren't necessarily necessary, but they had the means to do that. And in other places, we just don't have the means. And so, yeah, it's definitely a topic that should be looked at.
Yeah. Well, thank you so much. Great presentation.
Was indeed a great presentation, and me myself, I was very excited about this topic because in my practice, I have to do a lot of liver interventions, and you always want liver to be evaluated in detail by imaging, right? Before you would want to put your needle inside. But unfortunately, we don't have many MRIs readily available in our part of the world. So it was a good presentation and really a good insight into liver lesions. Is there any other questions in the end from anyone?
I think I do not see any more questions from the attendees. So I think we're good. And Mother, Dr. Terrazas, is really, really good one. You hit to the point every case. Thank you.
Thank you. I'm really happy to be here. I appreciate it. I appreciate you inviting me.
Okay, so on this note, maybe I would like to end our session for today, and I will be happy to join all of you in our next session.
Thank you.
All right.
Thank you.
All right. Thank you, Mother. Thank you.
Thank you, guys. I appreciate it.